So, okay, today I am planning to basically touch on peripheral nerve injuries. Quite a simple topic. Try and recollect anatomy, more of anatomy, and you can self-examine in the hall only. You can do the whatever you don't understand, the tendons, nerves. You can visualize yourself in the whenever you are reading. Okay.
Yes, sir.
Okay, we'll start with some MCQs as usual. Tinel sign used in, okay, to assess the severity of the nerve injury, to classify the type of the nerve injury, locate the site of the nerve injury, assess the regeneration. Anybody just try and attempt this question. Very interesting. Of course, there are so many questions on tinel sign, but most
The to assess the regeneration, sir.
yes, it is to assess the regeneration. Understand? Regeneration of a injured nerve. Okay. Others also please follow. Tinel sign is not used for severity of the injury. I will come to that later. Huh? Okay, this I wanted to just highlight so that tinel sign, that's what I keep telling Roshan. You try and look and remember the images, then you will remember for long. Okay, so what is tinel sign? Tinel sign is you gently tap on the nerve. You gently tap on the nerve. Whenever you gently tap on the nerve, there is a tingling sensation, abnormal tingling sensation in the distribution of the nerve, in the sensory distribution of the nerve. Please remember this. So commonly you can experiment yourself whenever you try to tap gently behind the medial epicondyle, that is ulnar nerve, isn't it? That vague, strange sensation what you get is not tinel sign. It is one, it will help you to understand what is the tinel sign. Okay. So when the tinel sign happens, nerve generally is covered by, this is a nerve, the axon covered by myelin sheath. Say for example, I'll draw a nerve here. So axon and covered by the myelin sheath. Okay, so whenever this myelin sheath is damaged, the axon is naked. Axon is not covered by any coverage. Okay, myelin sheath is not a protective covering. Remember, there is a endoneurium, perineurium, and epineurium. They have coverage which gives a support and blood supply. So whenever the nerve is injured, all those structures are injured. This is naked. There is no covering. So it becomes hypersensitive to the touch. So if you touch here, suddenly there is an abnormal electric shock like sensation wherever the nerve is distributed. I have demonstrated here about the median nerve at the wrist. This median nerve here, there is a carpal tunnel. Median nerve goes under this carpal tunnel. Okay, so there is the general nerve supply is for 3.5 fingers. 3.5 fingers. 3.5 fingers. Okay, please remember this. So why I'm telling this is, if you tap so on the naked nerve which is injured, They will get an abnormal sensation. I'll go thing I told only to make you understand what is the kind of abnormal sensation. What happens? What is a Tinel sign? So you know what is a Tinel sign. Okay. So what is the importance of the Tinel sign? You will know whether the nerve is interrupted or there is a process of regeneration. Okay, I'll come to that later. So how you do Tinel sign elicit is you should know the surface anatomy of the median nerve. So if you know the surface anatomy of the nerve, you go on tapping on the surface anatomy of the nerve. Whenever you elicit the abnormal sensation, that is a point. You mark this with a marker, some ink, indelible ink. Okay, indelible ink. So what you do, the patient again comes next week. So again you repeat the maneuver of tapping gently on the surface anatomy. That time if you get sensation at this point, mark that with the indelible ink. So this gives us idea that nerve is recovering like this. From proximal to distal, the nerve recovery is happening. So the Tinel sign, wherever that is elicited, it goes on migrating or marching anteriorly. This gives us that the nerve recovery is happening. That's why there was a question saying that Tinel sign is used for regeneration of to know the regeneration of the nerve. Okay. So nerve biopsy. Please remember, nerve biopsy in leprosy is usually taken from. Yeah. Anybody? I am not able to see who else is there, but please try and attempt to answer. Yes. Ulnar nerve, median nerve, popliteal nerve, sural nerve.
Sir, ulnar nerve.
Ulnar nerve. Anybody else? Anybody else? Okay. Wrong, Rushan.
Sir.
Ulnar nerve, wrong. I'll tell you why. See, whenever you are doing a nerve biopsy means you are taking a piece of the nerve. Some piece of the nerve is taken away. So ulnar nerve, please remember it is a musician nerve. Musician nerve. Median nerve is a laborer's nerve. Laborer. Manual laborer's nerve. Popliteal, there is no name, sural nerve. So you remember these are very, very important nerves. You cannot remove the piece of the nerve. So certainly it is not ulnar, it is not median. Popliteal, you remember common popliteal or lateral popliteal causes foot drop. So it is not all this nerve, it is sural nerve. Sural nerve is a sensory nerve along the lateral aspect of the ankle. It becomes subcutaneous at the lateral aspect of the ankle. Remember that. Okay. Medial side, it is a saphenous nerve along the greater saphenous vein. Sural nerve along the lesser saphenous vein. Please remember. Okay. So laterally there is a lesser saphenous system. Medially there is a greater saphenous system. Nerve associated laterally is sural nerve. Medial it is a saphenous nerve and saphenous vein. Sural nerve is a sensory nerve. So if you take even a piece of the nerve, only some part of the skin sensation is affected, which has already happened in the leprosy. And already there is a hyposthesia or paresthesia. It doesn't cause much morbidity because of taking out a piece of the nerve. So please remember, you have to take from a piece of nerve which is superficial, which is only sensory. The piece taking out will not damage the function of the nerve. Okay, understood?
Yes, sir.
Please respond. Okay, good. So this is what I wanted to show you. This is the lateral aspect of the ankle. There is a shorter saphenous vein goes posterior to the medial malleolus. Lateral malleolus. Medial side, there is a long saphenous vein. Whenever I am saying this, look at your own leg. You can see the vein if you are thin. You can see the vein, isn't it? Dorsal palmar. So greater saphenous vein, there is a nerve along with that is a saphenous nerve. Lateral side, you cannot see the short saphenous vein. Along with that, there is a sural nerve. Okay, so that's how you remember. You learn with image, learn with association, learn with mnemonics. Understand? So this what I wanted to tell you about sural nerve biopsy. See why it is picked up, why it is important, why you choose sural nerve. There are so many nerves available in the body. Understand? So the reason behind easily identifiable, easily you can identify. Purely sensory, no motor deficit following the biopsy. Liable to be affected by neuropathy because it is distal branch. Okay, this you need not remember. One more important thing is here, the person is not doing a biopsy. He is harvesting the entire nerve. This is a nerve or tendon harvester. Understand? So, sural nerve is a everybody's darling. One is for biopsy, second it is for one is for biopsy, second it is for grafting, nerve grafting. Whenever you need a nerve tissue, so just like bone grafting, skin grafting, you do nerve grafting also whenever there is a loss of nervous tissue. That time also you use a sural nerve. Okay, right. Which of the following is true about the nerve injury? In all cases, open injury with signs of nerve injury, immediate exploration should be done. Nerve conduction is best predictor within 48 hours. Positive tinel sign indicates accurate location of the nerve injury. Traction nerve injury needs to be repaired immediately. So remember, there is a correction in the question. Which of the following is true about nerve injury? So one by one we'll do. So for that you should know whenever you read nerve injury, it is
question is asked for false, sir.
Yeah.
Question asked for false.
Which is true? Which is true?
Oh, actually,
Which
except
is true?
you told
No. Which
except.
is no. Mistake. Which is true? Only one answer. Which is true? So you try and rule out the simpler choices first. If you are stuck with the first choice, look for the second choice, third choice, rule out which are obviously wrong. Then when you are stuck with one or two options, you can easily take a guess between the two options which are left.
The third option is rule out, sir.
Yes, positive tinel sign does not give the accurate location. Correct. It is ruled out, isn't it? Okay. See, traction nerve injury leads repair immediately. So, do you remember traction nerve injury where it happens? Traction nerve injury in crutch palsy. Crutch palsy. I will explain that later. Second, similarly, you can remember Saturday night palsy. It is actually
radial.
Saturday night palsy. It is a stretch traction nerve or stretch palsy. So, do you repair that immediately? Do you do surgery for a Saturday night palsy? No, because it is a neuropraxia. Recovery is 100% guaranteed. Understand? So traction nerve injury is not repaired immediately. Tinel sign is not an acute indicator for a location. Now comes these two. Nerve conduction velocity is a predictor within 48 hours. This is wrong. This only after 1 week of injury you will pick up the nerve conduction velocity changes. Regarding nerve conduction velocity and EMG and strength duration curve, these words you remember. If time permits, I will explain subsequently. Please remember these words. With respect to peripheral nerve injuries, you will have to learn 1 or 2 points. Okay. So what happens? This is again wrong. So in all open injury, suppose you think there is an open humerus fracture. When you examine, you see there is a wrist drop in the casualty. There is a open injury. It can be an open injury, fracture or without fracture. Suppose there is a gunshot injury in the arm, no fracture, but you see there is a wrist drop. There is a wound corresponding to the anatomy of the corresponding nerve, and there is a distal nerve deficit. That means definitely because of the wound, penetrative wound or otherwise blast wound, there is a nerve injury. That's where you have to explore the nerve immediately. Their meaning here is, please understand, you are doing only exploration. Why you want to explore is, first you should explore the wound. And once you reach the nerve, you will see whether it is completely cut or it is only there is a superficial damage or there is only hematoma around the nerve. So you should look for the anatomy of the nerve, how it is there. This is what they mean by nerve exploration. So by that you will know what we have to do. If the nerve is completely cut, whether you want to repair immediately, primary repair, delayed primary repair, or secondary repair. Please remember, primary repair is less than 6 hours, more than 2 days, more than 1 week. So this time duration you go and refer again. That is not important for me. They are not the questions which are asked generally. But what is important is, when do you do primary repair? When do you do primary repair? When do you do primary repair is when there is a clean cut wound. There is a clean cut wound. Imagine there is a glass injury at the wrist, cutting the median nerve, or a kitchen knife in the kitchen. There is a cut in the wrist, or suicidal attempt. There is a clean cut nerve injury. That time you do primary repair. Primary repair, within 6 hours you take up in the surgery and repair it. Rest of the delay is basically, if it is not a clean cut, the wound is not clean, you have to delay or wait for either delayed primary or secondary injury. Please remember this. Rest of it is not important. When do you do is primary is if there is a clean cut. Otherwise you wait. Simple. So, okay. All are indicator of good prognosis in nerve injury, except come on, neuropraxia, young age, pure motor injury, proximal injury. Take a guess, take a guess. Don't be afraid that you'll be wrong.
Pure motor nerve injury.
Okay, anybody else? Who is this, Pooja?
No, sir, Radhika.
Who is this? Radhika, okay. Yeah, anybody? Anybody else? Any other choice? Okay, you are wrong. See, one thing you remember, neuropraxia means there is you understand what is neuropraxia. Neuropraxia, the nerve will be intact, so it will be injured only because if it is stretched or if it is prolongedly compressed. So when is that possible? Saturday night palsy is prolonged stretch or prolonged compression. Where prolonged compression happens? Tourniquet palsy. So remember, neuropraxia is the nerve is anatomically intact. There is only physiological disruption. This is a physiological disruption of conduction of nerve impulse. Anatomically, the nerve, if you open this nerve, accidentally you will see everything is fine for your naked eye. But there is a physiological interruption. Physiological interruption means suddenly it can always improve. So it is not neuropraxia. Young age for that matter, any tissue healing is good. Bone, nerve, or any injury heals well with in younger age. So this is a good prognosis. Pure motor or it is also good prognosis. Here you have to remember certain things. Good prognosis is for both pure motor or sensory. If it is a pure motor or a sensory nerve injured, it good prognosis. I'll tell you why. Proximal injury, this is a problem. More the injury is the distal, recovery is better. So bad prognosis is in mixed nerves. If it is a pure motor, pure sensory, good prognosis. If it is a mixed nerve, it is poor prognosis. Good prognosis, for example, radial nerve. Radial nerve is predominantly motor. Similarly, sural nerve or other sensory, purely sensory nerve, again the prognosis is good. I'll tell you why. See, if there is a mixed nerve, there are so many nerve bundle fibers here. Some are sensory, some are motor. Say for example, motor, sensory, motor, sensory, motor, sensory, motor, sensory. So once it is cut, the axon has to regenerate, isn't it? It has to regenerate like this. It doesn't know. It is blind. The blind progression of the repair happens. So sensory, this becomes sensory. Here there is a motor. Here there is it has to end in motor unit or it has to end in sensory organs. So it doesn't know where it ends, whether it ends motor axon go and end here sensory, and sensory will go and end at the motor end organ. So that's why the prognosis is poor in a mixed nerve. But on the contrary, if it is all sensory, so anyway it goes and ends on the skin invariably. It goes and ends on the skin. If it is pure, it goes and ends on the musculotendinous contractile unit or end organs. Remember this. Okay? Am I clear? Am I clear?
Yes, sir.
Okay. A pole vaulter had fall during a pole vault, had his arm paralyzed. Which of the following investigation gives the best recovery prognosis? Very simple question, no confusion. Imagine a pole vaulter. Pole vaulter, you have seen the sport, isn't it? He takes the pole and jumps across a hurdle. So technically it is a what? Technically it is a stretch injury. It is a stretch injury. So what you do in stretch injury? You don't do muscle biopsy. Is it of any help? No use.
Yes, sir.
CPK levels, it is of no use, isn't it? Yes, Roshan, you are saying something.
EMG, sir.
EMG is the correct answer. Okay. Remember one thing, strength duration curve is not so often used. EMG, I'll come to that subsequently. EMG is the correct answer. So again, this is one more important. Motor march. Motor march is seen in. Yeah, please.
Axon.
Yeah,
Axontomesis.
very good,
Axon.
very good. Axonotomesis. Neuropraxia, no. Neurotomesis, definitely no. All of them, no. Do I need to explain this? So there is two classification.
Proximal to
Sedons,
distal recovery.
Sedons and Sunderland's classification.
Yes, sir.
Okay. Sedons is simple 3 types. Sunderland's is 5 types. 5 types. Simple. Remember, Sedon is a less letter word, 3 types. Sunderland or many letters, 5 types. Simple mnemonics. Too many mnemonics is finally you end up not remembering what each word explains. These two classification helps us to classify what is the severity of the injury. Remember this. Severity of the injury, either sedans or simple is sedans by 3 types. Here are the 3 types. First is this neuropraxia. Second is axonotomesis. Third is neurotomesis. This is the sedans classification. Sunderland's classification will not go. That is not generally necessary. But please remember these 3 simple classification of sedans for severity of the nerve injury. So how it happens is there's a nerve here, nerve bundle. In the small nerve fibers will be there. In that again there will be a picture like that, isn't it? Which is expanded. This is the axon. So neuropraxia, as I said, it is only physiological injury, no traumatic injury. You remember, so it is a neuropraxia. So if it is whenever there is a partial cut, or if there is a stretch in the nerve, too much stretch, you pull a rope. Two of them, if they pull a rope, initially it only stretches a while and comes back. If you still use a machine and stretch it, some fibers get torn, isn't it? So that can be axonotomesis. If there is a complete tear of the rope, it means it is a neurotomesis. So okay, I forgot that. So what is motor march is? What is motor march? You said the answer is correct.
Proximal to distal recovery.
Yes. So if there is a radial nerve, imagine there is a radial nerve injury in the spiral groove. It supplies the triceps, then anconeus, then comes your brachioradialis, then comes your extensor carpi radialis longus, extensor digitorum, like this. And this list is not exhaustive. So if there is an injury in a radial groove, if you observe for a while or with physiotherapy and conservative management, you will see the improvement in the triceps first. Then you see improvement in the anconeus. So it is marching. The march past, the January 26 march past, what you see in the RD parade or near the India gate, see that is marching. It is marching ahead. So the proximal to distal improvement of the muscles in a nerve injury is motor march. Okay. So where are we now? Which of the following is not true about the Mcqs paralysis? Yeah, go ahead. Please read the question. So involves lower trunk, intrinsic muscles are paralyzed, claw hand is a feature, Horner syndrome can never be associated.
Four, sir.
Horner syndrome
Yes.
associated.
Horner syndrome can be associated.
Horner
Very
syndrome
good.
can be
Very
associated.
good. Very good. Very good, very good. I am happy the others are responding. It will be interesting if you communicate. Okay, good. So no need of explaining much here. So Klumpke's is lower cord injury, that is C7T1. Most commonly, intrinsic muscles are paralyzed. So whenever intrinsic paralyzed are, claw hand is a feature. Okay. Horner syndrome is because of the T1. It is most of the times or almost always Horner syndrome is associated. I will not go and get into the Horner syndrome. Okay, this some picture I am just showing for brachial plexus injury. Brachial plexus injury. It can be birth injury or it can be adult wherein adult injury. So we'll concentrate on birth injury. So this is a typical Erb's palsy. This is typical Klumpke's palsy. Erb's palsy, you remember, upper C5, C6. I don't know whether you can see this. This diagram is not good. Okay, I'll come to that later. So please remember, Erb's palsy is the typical attitude of the limb is the policeman tip hand. Also, it is called as policeman,
Policeman,
porter,
waiters, tip.
and or waiters. Whosoever is taking tip. Of course, nowadays you give tip uh, from front only. You don't have to hide and give tip. This was a tradition which was being followed when tipping was not legal. Nowadays, tipping is more legal and they demand 10% of the total bill. So, policeman or porter or waiter's tip hand. This is the typical attitude. If you remember this attitude, you will know what are the muscles paralyzed. So it is hanging by the side means abduction is not possible. Pronated means supination is not possible. And there is a flexion of the hand means wrist extension is not possible. If you remember this attitude, you will easily say. Then comes your Klumpke's palsy. Klumpke's palsy is C7T1 lower trunk injury. It causes claw hand. I will explain claw hand in detail in subsequent slides. So this is one slide. In adults, how it happens. So this is shoulder dystocia. When you try to deliver a child where his shoulder is stuck and you pull the shoulder. You imagine yourself hyperabducting the arm. You do it there wherever you are sitting. So in hyperabduction, lower trunk injuries happen. So if a patient is falling from height, suddenly he will catch a trunk of the tree. There is again hyperabduction. So that is Klumpke's paralysis. Here again, if patient is involved in RTA, suddenly there is a lateral bending of the head. There is a stretching of the upper trunk. That causes Erb's palsy. Okay, this is some diagram you please remember again. See, this is a child with a Erb's palsy. Look at the child, typical attitude. Look at the child here, the hand. The child can move the shoulder, elbow, everything. The hand is simple, it is a form of clawing. Clawing, okay? So this is again, see, in this delivery, what happens? Upper trunk is injured. Remember, you stretch the neck of the child. Upper trunk injury happens. This hand signals I will explain later. Okay. Brachial plexus. Yes. So this is what I wanted to remember. You please remember and recollect this. C5 to T1 roots form a brachial plexus. I will not go into the anatomy of the brachial plexus. It is only to applied anatomy so that you remember. Upper trunk injury, Erb's palsy. Lower trunk, CAT1 is Klumpke's palsy. Axillary nerve is least likely. Axillary nerve injury is least likely in. Yeah, simple, no brainer. Anybody can answer this. Quick.
Shoulder dislocation.
Shoulder dislocation. Anybody?
Improper use of crutch, sir.
Improper use of crutch.
Yes. Isn't it? So you remember the anatomy of the shoulder. Your axillary nerve is somewhere here. Okay. It circumflexes around the surgical neck of the humerus. So if there is a shoulder dislocation, if there is a fracture here, proximal humerus fracture, shoulder dislocation, some people in deltoid, here there is a deltoid, isn't it? Untrained people giving a deltoid injection can also damage this. Crutch, no, crutch is causing lower trunk brachial palsy. It doesn't cause a axillary nerve injury. Remember this, okay? Yeah, this is one picture what I wanted to show. Look at this contour of the deltoid. There's a loss of the contour of the deltoid. There is a impaired sensation here. I remember what is the sign, Roshan?
Sir,
When axillary nerve is injured, there is a loss of contour of the
regimental.
deltoid. Regimental badge sign. So the army people wear a dress where there is a badge here, isn't it? There's a badge here on the side of the arm. That portion is anesthetic. Anesthetic. Okay. So loss of contour of the shoulder. Remember, this loss of contour of shoulder is because of deltoid wasting. Okay, remember this. Loss of contour of the shoulder can be seen in shoulder dislocation. Remind you, I'm reminding you. Here it is very nicely, movements are there, passive movements are there. In shoulder dislocation, passive movements are also absent. In waist deltoid axillary injury, passive movements are there, but active abduction is lost. There is a loss of sensation on the lateral side of the arm. Okay. Okay. So all of the following are observed following axillary nerve injury, except very interesting question. Come on. Few more time. I mean, we have 20 minutes.
Sir,
Yes.
patient cannot initiate adduction, sir.
Very good. Abduction. Patient cannot initiate abduction because initiation of the abduction is by.
Sir,
Yes.
pronator.
No. Supraspinatus.
Sorry,
Supraspinatus.
sir.
See, there is a shoulder here. There is a supraspinatus attached here. Initial abduction is with the supraspinatus. Later abduction is by the deltoid.
Deltoid.
Okay. So, what is the answer? Wasting of deltoid is yes. Extension of shoulder at 90-degree abduction. So deltoid is tripennate, isn't it? It has anterior, lateral, and posterior. So it helps in abduction and extension. Of course, extension, there are other muscles, but it is a secondary action of the deltoid. Again, numbness of the lateral arm, as I said earlier. So remember, read the question carefully. If you just read abduction, you will miss this. So patient cannot initiate abduction is what is important. Patient presents with a loss of sensation of lateral 3.5 finger. Map it on your hand, lateral 3.5 finger. See, that is the advantage of orthopedics and anatomy. You can do it yourself whenever you are sitting. So which is the additional finding? Patient presents with a loss of Sensation of lateral 3.5 fingers.
Median nerve injury, sir.
Median nerve injury. Very good. So now you read the choices. See
Abductor
here.
Loss of
pollicis.
sensation over
Abductor pollicis, sir.
See, read this. There's nothing
loss
called
of
abductor.
sensation over thenar elements.
One. Okay. Anybody else? Anything else? See, read this question carefully. Atrophy of the adductor pollicis, it is not possible because it is supplied by ulnar nerve. Remember? You know this? You should know this. Okay. I will help
Sir,
you in answer.
when we following the pain test, sir,
Hmm.
is the for abductor pollicis brevis.
Adductor, read this. Adductor, it is adductor.
Oh, sorry, sir.
You understand?
Yes, sir. Yes.
That is a mistake. Pen test, you are correct, but that is abduction, isn't it?
Yes, sir.
So the answer is opponent's pollicis. Thenar muscles. So for that you should know there are 20 muscles in the hand. Okay? 4 thenar, 4 hypothenar, 4 lumbricals, 4 dorsal interossei, 4 palmar interossei. 4 into 5. I don't know whether you have been taught, but please remember it is 5 groups of 4 muscles. Very, very simple. So if I tell you the names of the muscle also you can remember, but I think it will be too complicated. I will not explain you. You go and read the anatomy. This is helpful for identifying the nerve injury. So 4 thenar muscles, median nerve, except adductor pollicis. Thenar muscles means what? All are connected to thumb. Remember this. All the muscles acting on the thumb are supplied by the median nerve except the adductor pollicis. Okay? So what is remaining now? I told ulnar nerve. I told ulnar nerve is a musician nerve.
Yes, sir.
So all the remaining muscles are supplied by ulnar nerve. But there is a rider here. So to make lives very, very simple, I will tell you there are 20 muscles as I told you, 15 plus 5. Majority, ulnar is a musician nerve. Hence it is majority muscles are supplied by the ulnar nerve. 5 muscles are supplied by the median nerve. Okay. Now you remember. I told 4 thenar muscles. Out of that only 3 are supplied by the median nerve. Are you following me?
Yes, sir.
Okay. So there are 5 muscles supplied by the median nerve. I said 4 thinner group of muscles supplied by the median nerve, out of which one is eliminated. So 3 thinner muscles. So what are the 2 remaining? 2 remaining lumbricals. Lateral 2 lumbricals. Is it not easy to remember? 15 plus 5. 15 plus 5. 15 ulnar, 5 median. Median, all 3 thenar muscles plus 2 lumbricals. So remaining 2 lumbricals, all dorsal and palmar interossei hypothenar muscles, and 1 thumb muscle, that is adductor pollicis. Pollicis is thumb, pollex, thumb, hallux, great toe. Remember this. Am I clear?
Yes, sir.
Okay, good. So ape thumb deformity is observed in.
Median nerve.
Very good. Ape thumb deformity is observed in median nerve. It's a no-brainer. We'll go to the next. So remember this. I put a picture only to make you remember this. So ape thumb deformity median nerve. So that's where you came your pen test. Remember?
Yes, sir.
Remember? So you cannot try to touch the pen with the thumb. You cannot abduct. Look at the thumb which is in same plane with the other fingers. This is ape thumb. Ape is monkey, isn't it? Ape thumb deformity. Thenar eminence is lost. Wasting is there. You cannot touch the opposite. See why they call it as ape thumb is your thumb in human being is at 90 degree to the hand. You can touch the thumb of tip of little finger and the thumb, but ape cannot touch this to here. That is because monkeys do not have opponents and other thenar muscles. Easy to remember. Am I clear? We'll go to the next slide. Okay, so patient comes with the complaints of difficulty in adducting his fingers, read carefully. Flexion of the extended MP joint. Imagine this. So you do it whenever you write solving mathematics, you write. Whenever you're reading anatomy and orthopedics, you do that on yourself. Then you will know. So he is finding difficulty in adducting the fingers, and flexion of the extended MP joint. So what are the muscles paralyzed? Easy, isn't it? See, in this case, what you do, flexor digitorum profundus is gone, flexor carpi.
Interosseous, sir.
So now you are stuck between introssei and lumbricals.
Interosseous, sir.
Because there is something called as pad and dab. Isn't it?
Yes, sir.
Palmar introssei, adduction, dorsal introssei, abduction. Okay, good. So ulnar paradox. Quick. Come on.
Guidance, can I?
No. You should remember this. Anyway, no issues if you don't know. See, first you should understand what is ulnar paradox. See, whenever a nerve is injured proximally, deformity is more. But in ulnar nerve, whenever nerve is injured proximally, deformity is less. Remember easily, you can remember now. So higher the injury, deformity is more. This applies to all the nerves, but not the ulnar nerve. I'll tell you why. See, what does the ulnar nerve injury cause? It causes the clawing of the hand. Claw hand, isn't it? So clawing of the hand, if nerve is injured higher up, clawing is less. If injured lower down, clawing is more. This is a paradox. Okay? You will know this if I explain you the anatomy. So ulnar nerve supplies the forearm flexor muscles also. FDP. Okay? And then supplies the lumbricals also. So lumbricals, what happens in the hand? Lumbricals are strange muscles. it attaches, originates and inserts from tendon to tendon only. Okay, it originates from a flexor tendon and attaches to extensor. What is that? Expansion. Please remember, lumbricals attaches from tendon, from flexor tendon to extensor expansion. So I will not get into that. So how to explain that? Okay. So if ulnar nerve is injured higher up, the tendon flexor digitorum profundus basically and FDS also injured, and lumbricals also injured. But if it is injured distally, the forearm muscles are spared, only lumbricals. Lumbricals are injured. The reason for clawing of the hand is lumbrical paralysis. Claw hand is also called as intrinsic minus hand. Intrinsic minus hand. Please remember, they might ask you this time, I don't know. So if there is no action of intrinsic, that is intrinsic minus hand means ulnar nerve injury is there, clawing is there. So simple, you remember, higher the injury, lesser is the deformity. I'm not sure if I can explain you any better now, but if time permits, I'll explain you again later. Okay, so I was mentioning about this. What is ulnar paradox is, higher the lesion, less obvious is the clawing of the deformity. More proximal injury, less clawing. Okay? Okay, this one, I will come to this little later. There is you should remember benediction, sign of benediction and clawing. You have to remember the difference. Okay, sign of benediction is in median nerve, clawing is in ulnar nerve. Okay, I will explain to you that later. Yes, again here. See, this is clawing. This is sign of benediction. Both look similar, but remember, clawing is a resting position. It is a resting position. Okay, but sign of benediction is you ask the patient to make a fist. You ask the patient to make a fist. The index and the middle finger does not flex. Why this does not flex is FDP, flexor digitorum profundus, is paralyzed. Why it is paralyzed? Supplied by what? Median nerve. So no flexion. So sign of benediction is an active sign. It is an active sign. Claw hand is a passive sign. Claw hand, if you see, a patient will have this posture already. There is a clawing here. But the patient in sign of benediction will have a normal hand. But when you ask him to make a fist, only the fourth and the fifth finger flex. First and second finger remain extended because of paralysis of the FDP, because of the median nerve injury. So the hand looks similar, but this is, you ask the patient to do fisting, then it will appear like this. Claw hand is already like this. There is one more thing, similar hand is, you should know, depütans contracture. Also, there is a similar to like the claw hand, but here there is again flexion of the MP joint or MCP joint. Yeah, please remember, go through this table. Difference is claw hand. Hand of benediction in median nerve. Remember this. Nerve involved. Ulnar nerve in claw hand. Easily median nerve. Don't go where it is involved at the elbow or the wrist. Typical presentation in long-standing cases appears when the patient makes fist. Similarly, there is in median nerve, you know, there is something called as Ochsner's clasp sign, or pointing index. These are all signs of median nerve. Okay. So digits affected: ulnar claw hand, the medial two fingers, fourth and fifth. Median nerve, second and third. Are you following me? Will not go into the movements involved. Okay. Following a sharp incised wound in front of the wrist, he is unable to oppose the tip of little finger to the thumb. Yeah, very easy question. Answer this. You cannot oppose the tip of the little finger to the thumb.
Median nerve.
Very good, very good. There's nothing much. This is like ape thumb. You remember? There is no opposition. And where is median nerve situated? Just near the wrist, under the carpal tunnel. Yeah. So they have given an indication here. They have already given a incised wound in front of the wrist, and opposition is lost. Answer is median nerve. Read the question carefully. Tendon used to repair flexor tendon injury in the hand. Reconstruction of forearm to fingertip. So from forearm you have to use a tendon graft. So I told you skin graft, bone graft, nerve graft. Now there is a tendon graft. So graft is what you take from. So now you know. Okay, but there is a hitch. Whether it is palmaris or plantaris. So you are ruled out. No, answer is wrong. Here remember plantaris. You require a long length here. If it is from the wrist to the fingertip, use a palmaris. If it is from the forearm to the tip, you require a long length, it is a plantaris. Okay, Roshan. Do you understand? Plantaris is longer, you will require a longer length. So both can be used. But when you require a short segment, use palmaris, long segment, use plantaris. Which of the following is used as a substitute for a wrist extensors in a radial nerve palsy? So radial nerve palsy causes wrist drop. Okay, so whenever I am doing a radial nerve injury will not recover, I am doing a tendon transfer. So I want one motor, one tendon for the wrist extension, one tendon for the finger extension. Isn't it? Logic of the doing operation. So I want some muscle. So all the extensors are lost. We have to take muscles from the flexor compartment. So one for the flexor compartment, one muscle for the wrist extension, one muscle for the finger extension. So you have to take from the flexor compartment of the hand. So you have FDS, you have FDP, you have palmaris longus, you have teres, pronator teres. So one thing you ruled out, palmaris longus is a useless, because it doesn't have it can be taken away completely as a tendon graft. It cannot be used for a tendon transfer. Tendon transfer means origin is still attached, only the insertion is taken, reattached. Okay, so one thing is for sure, palmaris longus has gone. Now you have FDS or FDP. FDP you cannot take. So you have to take FDS or pronator teres. So pronator teres is ending close to the wrist. It ends in the middle third of the radius, isn't it? So pronator teres for the wrist extension. FDS is for the finger extension. Please remember. Wrist extension you use pronator teres. Finger extension use the FDS. So FDS you use, there are 4 slips, isn't it? 4 fingers, 4 slips are there. You use only ring finger FDS. Okay? You remember this much is important. Extension of the MP joint. Extension of the MP joint of the hand is lost in injury. So extension of MP joint means here is what? Finger drop. Wrist extension is lost means what? Wrist drop. Okay. Are you following me? So
Yes,
now
sir.
you have to find nerve which causes finger drop. Anterior introitius is a median nerve, part of the median nerve. Ulnar nerve will cause clawing. Okay. Median nerve, no, definitely neither median nerve nor a anterior introitius nerve. What is remaining? Posterior introitius nerve, which is coming from a radial nerve. So a proximal injury will cause a wrist drop. Distal injury or a posterior introitius nerve injury will cause a finger drop. Injury to the radial nerve in a lower part of the spiral groove. This is one interesting question I have picked up. Please go through this. This is very, very interesting. 2 more minutes. I will finish up. Okay. Please follow this question very carefully. Injury to the radial nerve in lower part of the spiral groove. You know, spiral groove is there. Where it is there? Spiral groove is there. Yes, Roshan.
Yes, sir.
Where it is situated, spiral groove?
Sir, humerus, sir.
Very good. Middle third of the humerus. So lower part of the spiral groove, it is radial nerve is injured. So read the question carefully.
Spares
So
nerve supply to ECRL.
spares the nerve supply to ECRL. Okay, we'll see that. We'll analyze each one. Paralysis of the anconeus. No, because anconeus is spared. Leaves the extension at the elbow intact. Elbow extension is intact means what? Elbow extension means what? Triceps is spared.
Yes, sir.
Pronation movement lost means it is not important because it is a flexor or a volar compartment where it is only median nerve. I am not interested. So this goes away straight. So now your answer is spares ECRL, spares anconeus, spares triceps. No, anconeus is paralyzed, isn't it? So now you tell me whether it spares ECRL or it spares the elbow. Who was that who answered?
Elbow, sir.
Yes?
Sir, elbow, sir.
Yeah. Now you understood, isn't it? So ECRL will cause a wrist drop. It
Radial
is an
nerve.
extensor of the wrist drop, extensor of the wrist. So wrist drop, it has to happen. Means it cannot spare. It is not spared. But elbow extension is spared. Radial nerve in the spiral groove causes wrist drop. Remember this. So wrist drop means extensor tendons are paralyzed. ECRL,
UCRB.
B, ECRB and ECU. See, there is no big confusion. On radial side there are one muscle and ulnar side one muscle. Radial side there is one extra muscle. So these are paralyzed, isn't it? So this is the wrong answer. The answer is this one. Cock-up splint is used in the treatment of. Quick. Anybody is tired and want to leave the class? Let me know.
Radial nerve injury.
Very good. Radial nerve. So I have demonstrated some pictures here. See, cock-up splint with the spring, dynamic cock-up splint. They are used for a wrist drop. Means so wrist is dropped like this. You want to keep it in a dorsiflexion. That is cock-up. You keep up the wrist up. That is cock-up splint. So here it is kept always like this. Here what happens? Spring is there. Here you see the patient can do flexion also. Only the wrist extension is lost, isn't it? The flexion is there. So you can ask the patient to do flexion. It goes back into the extension because of the spring. This is knuckle bender splint. Knuckle bender splint. So any splint for that matter does the opposite movement, which is paralyzed. See, in claw hand there is a hyperextension of the MCP joint. Hyperextension. So now you want to keep it flexed. There is a flexion of the interphalangeal joint. You want to keep it in extension. So this knuckle bender splint is for ulnar nerve. You can remember ulnar, UN in this. Knuckle ulnar. Yeah, this is some picture about foot drop splint. This is dynamic. If wherever there is a spring is there, it is a dynamic splint. Foot drop splint is used for foot drop. Last two questions. Common injury to the common peroneal nerve at the lateral aspect of the fibula neck results in all except. This is very interesting question. All of you focus this. This is very, very interesting question. See, dorsiflexors are weak, that's why it goes for a foot drop. Okay? Now between ankle reflex is lost or there is a sensory impairment of the lateral aspect. So which one of the two? This is, remember, this is accept. The answer is loss of ankle reflex. So what happens in ankle reflex? Tendo Achilles contracts. Remember this.
Yes, sir.
Tendo Achilles contracts. So nothing happens to tendo Achilles. Foot drop, tendo Achilles is intact, isn't it? In fact, it is overacting. That's why foot goes for dropping. Did you understand this question? So the answer is this. Ankle reflex is normal in foot drop. Last question. A young lady sustained lacerated wound in the back of the thigh with a bull horn. Wound was sutured. 2 months later, she develops the foot drop. Most common scenario. And there is an ulcer on the dorsum of the foot. Likely diagnosis. See, foot drop means what? There is one motor nerve injury. There is ulcer means what? It is a trophic ulcer. Means there is a loss of sensation. Loss of sensation. There is a foot drop, there is a loss of sensation. So now comes a choice. Let us now look for the choice. Injury to hamstrings, no.
No, sir.
Okay. Chronic ischemia of the popliteal artery injury, no.
No.
It will cause gangrene, isn't it? So now it is partial sciatic nerve injury or a complete division of the sciatic nerve.
Complete division.
No, it is partial because there is only foot drop. The plantar flexion is maintained, isn't it? And there is an ulcer only on the lateral dorsum of the foot, not on the sole. Sole is normal means what? Tibial nerve is normal. So it is a partial nerve, sciatic nerve injury. Understand? One interesting thing about sciatic nerve is if there is a sciatic nerve, if you cut a sciatic nerve like this, the peripheral nerve fibers form the common peroneal nerve. The central fibers form a tibial nerve. So, sciatic nerve divides into common peroneal and the tibial nerve. So even though like this they divide later, but the arrangement is the peripheral fibers are common peroneal, the central fibers are tibial. That's why common peroneal is sensitive for pressure. So if you hit on the lateral side of the neck, there is a foot drop because only the peripheral fibers of common peroneal nerve are injured. Okay, am I clear? Thank you. So I exceeded the time by 10 minutes. Is that okay in case sometimes I exceed? Roshan?
Sir, no problem, sir.
This is odd hour, isn't it? Ghost period.
Yes, sir.
You are early riser or
Sir,
you read late night or read.
late night,
Okay.
sir.
Okay. How many are early risers?